disease after bariatric surgery, because this can be a problem that we're all familiar with and difficult to manage. This is a cartoon that shows you, as you all know, the different factors that are involved in producing GERD in patients, especially in the obese patients who have a lot of intragastric pressure, impaired accommodation, delayed gastric emptying, especially if they have diabetes and so on. And so you can see how all these factors can sometimes come together and really produce a picture that is very hard to manage. We know that GERD is intimately linked with obesity, and 60% of the patients who walk through our doors are expected to have reflux disease. It's something that we all understand. And we know that weight loss alone, whether it's through dieting or medications or surgery or endoscopy, can improve GERD, but it's not always 100%. And the reason why GERD can occur after surgery is because, as I will show you, bariatric surgery is not 100% effective against GERD. And so the higher the prevalence of the patients that we have, the more patients we will encounter in the postoperative period. Some operations tend to be refluxogenic, meaning that we think that they produce reflux, and I'll talk about that. And also, the magnitude of weight loss is proportionate sometimes to the improvement or not improvement of the reflux disease. Even in landmark papers like the ones that was published by Schauer's group back in 2002, and where they reported the improvement in comorbidities after gastric bypass, they did not say it was 100% effective against GERD. So you can see that heartburn, still patients had, 22% of patients had heartburn after 3 years, and many of them, 10%, were still on medication for GERD. So I think we all understand that it is not 100% effective. We're always going to have patients who have GERD, and some of them will be refractory or resistant to medications. Why does this happen? It could be that they have large pouches, whether it's a neofundus from the sleeve or a large gastric pouch from the gastric bypass. And this translates to a significant parietal cell mass, which are the cells that produce hydrochloric acid. It could be also that there's some inhibition of G cells and stimulation of acid production from these large cells. So, and we have done several studies using Congo red stains in the pouches that it's a red dye that turns black when exposed to acid, and we found that many patients after gastric bypass, some of them asymptomatic, had a lot of acid being produced in their pouches. And then finally, it could be that the vagal nerves tend to be overstimulated in some of these patients, and that's why some of the new technology that's coming out with vagal blocking might be helpful. So what about sleeve gastrectomy? As you know, the sleeve and its relationship with GERD is very controversial, and that's because we've had a lot of data that supports both schools of thought. This was first brought into our attention by Himpens back in 2006 when he was comparing his band patients versus sleeve patients. He noticed that a large number of his sleeve patients improved their symptoms of GERD. However, there was a 22% incidence of de novo GERD. This is the first time we heard of this, that developed 1 year after surgery. But then as he followed these patients for 3 years, he found that their incidence also improved over time from 22% to only 3%. But this made us think of why is it that sleeve patients get GERD. This is another study from Nicola Basso's group, 370 patients, and in his experience, a similar number of patients, 23% developed de novo GERD. And why this happens? In the sleeve patient, it could be because the motility of the stomach is changed. We know definitely there's an increase in intraluminal pressure, which resists the clearance of the esophagus. These patients have an intact pylorus, which might be working against the sphincter, the lower esophageal sphincter. They developed lower esophageal sphincter pressure as a result of taking down the angle of His, which is not a problem in gastric bypass, but very much of a problem in the sleeve patients. And in many cases, the sphincter is shortened, the lower esophageal sphincter. In our own data, more current now in the BOLD data, and this is data that was being accumulated from the Centers of Excellence patients. It's no longer active now, but it's available. Almost 5,000 patients who underwent a sleeve gastrectomy, and they found that the GERD incidence in pre-surgery was 44%. And of those patients with preoperative GERD, 84 had persistent GERD, 84%. De novo GERD was in 8%. And that these patients who had preoperative GERD did worse. They had more complications, they needed more revisions, and they had less weight loss than gastric bypass patients who had GERD. So there seems to be a problem with these patients. Now, there's another study of 32 patients, and these subjected the patients to both objective and subjective studies, pre-op and then at 3 months post-operatively. So the problem here is a short follow-up period. It showed that their symptom scores all improved, but the scintigraphy they did to measure or to demonstrate reflux actually was worse after surgery. And they found that some patients had new development of esophagitis after the sleeve gastrectomy. And more data that contradicts the first. Here's another 20 patients. In these patients, their GERD symptoms remained unchanged. Their pressure decreased from 18 to 11, as I explained, because of the takedown of the angle of His probably. And their acid exposure in the esophagus increased compared to preoperative data. And this is demonstrating the marked increase in all these parameters in these postoperative patients at 3 months. On the other hand, this is a paper from Baltasar, 700 patients who underwent a sleeve gastrectomy. Only 1% developed severe reflux symptoms and proximal sleeve dilatation. Only 1 patient required reoperation, and 7 were managed medically. And it could be now that as time goes on, maybe the operation is evolving better, and we're beginning to understand technical factors that might provoke GERD. And these are some of them. We know that we shouldn't be too aggressive in encroaching the lower esophageal sphincter when we're fashioning the sleeve. We know we shouldn't be too aggressive in selecting a small bougie, and we know that by doing that we increase the incidence of GERD. Also, all the other anatomical factors such as a stricture in the stomach can cause this. Also, obviously, the creation of a neofundus can help, and having a hiatus hernia that is more than 3 centimeters and remains unaddressed also results in GERD. And then we have to always remember to ask our patients exactly, carefully, what they mean by heartburn or what they mean by indigestion, and then maybe follow that up with a pH study, because many of these patients will be experiencing what we call pseudo-reflux, just difficulty with understanding the new symptoms that they're experiencing, and they just put that under a bucket and they call it, I have reflux. This explains true. So how do we evaluate for GERD in the postoperative, post-bariatric surgery patient? Basically, we want to look at the esophagus and stomach. We want to make some measurements of the acid, and we want to also make sure that the motility or the squeeze of the esophagus and the lower esophageal sphincter is normal. And we do that by endoscopy, as we've seen today. Obviously, if we see esophagitis, that pretty much proves that the patient has GERD. And we can do pH studies in these patients, and especially with the Bravo probe, which is my favorite because the patients tolerate that very well, and it gives you a true indication for 48 hours, and of course, manometry. So once we diagnose GERD in these patients, what are the options? I'm going to concentrate today on radiofrequency, delivery of energy endoscopically, endoscopic delivery of radiofrequency energy as treatment for postoperative GERD. And the reason I use this is because I found that to be a very acceptable option for patients who have had surgery and who carry the risk of revisional surgery. So for those of you who are not familiar with this device, it's called the Stretta. It's been in the market now for, I'd say at least 15 years. It 10 to 15 years. And this is a catheter that is placed endoscopically down the patient's esophagus, and you can see at the end there's a balloon that is inflated, and then there are these wires that are deployed and controlled by a button on the handle. And these wires reach out and penetrate into the esophageal wall and the sphincter wall and deliver radiofrequency energy, which then heats up the tissues to create the changes, the required changes. And at the same time, in order not to cause any permanent damage or burn, there is cold water that is constantly irrigating or infusing around the device. And also the generator itself has very sensitive readings of the temperature and the resistance in the system. So basically, we advance a guide wire, and this is guide wired directed, and we place the balloon. We identify the lower esophageal sphincter, and then we place the balloon for initial deployment at 1 centimeter above the Z-line or gastroesophageal junction, and deploy the wires and apply the energy. And then we go up 1 centimeter. So this is the first one. The next one is 0.5 centimeter above that, and then 2 more treatments above the Z-line, and then 2 below the Z-line. And then we do a retrograde one where we inflate the balloon and pull it back, and that way deliver energy, as you can see, along the undersurface of the sphincter. And this is the end result there. So the endoscopic view of this shows that immediately after delivery, you see these zones where the energy has been delivered. They create these areas of thermal thickening, which then increase the bulk in the area. And although the mechanism is not perfectly understood, we do know that it decreases the compliance of the lower esophageal sphincter. It decreases the transient lower esophageal sphincter relaxations that can result in reflux disease when they're abnormal. It increases the number and size of smooth muscle fibers and increases the proportion of collagen 1, which is the better collagen, compared to collagen 3, which can be associated with disease and weakness. So what's the data on this? Frankly, there's a lot of data. 14 years of data now, including 20,000 procedures. 14 years of peer-reviewed clinical data. You can see there are multiple 4-year studies. There are studies with 10-year follow-up, 8-year follow-up, and 3,000 plus patients in clinical trials. There's level 1 evidence. And SAGES has come out with a position statement on this, and it graded the recommendation as strong because of the quality of evidence was encouraging and supportive. And there are over 34 published clinical studies. This is a study, this is the position statement from SAGES, and where the recommendation is that Stretta is considered appropriate therapy of patients being treated for GERD who are adults and who suffers from the common typical symptoms of GERD. And then the ASGE also came out with guidelines that promoted the use of endoscopic management of GERD, particularly with Stretta. And their summary is that endoscopic anti-reflux therapy may be considered for select patients who have GERD. This is a meta-analysis of 18 studies that shows you the current data. It included data concerning symptomatic scores and quality of life, SF36 physical and SF36 mental, heartburn scores and satisfaction scores. And see, please, the columns on pre-Stretta and post-Stretta. It shows you the marked difference in an improvement in these scores, and they were all significant. Also, objectively, there are many studies that had pH studies and Demister scores, and again, you can see the significant improvement in these areas and in motility, all of which were significant. And this is durable. You can see that there's long-term data, 10-year data, 4-year data, all that show the majority of patients have normalized symptom scores, and many of them are off medications. And you can see the rest of the slide highlights this fact. And as for those of you who may be wondering exactly what the mechanism is, we know for certain that there is some thickness in the esophageal wall. You can see here the difference in these two slides between the baseline and 6 months. And there's a 50% mean increase in thickness at the GE junction. And this could be the contributing factor for these patients' improvement. So who qualifies for this? I think it's patients who do not want or are not indicated for surgery. Patients who are intolerant of proton pump inhibitors or have reached maximum therapy. Patients who have non-erosive reflux or laryngoesophageal reflux. Post-Nissen patients, and of course, post-gastric bypass and sleeve patients in whom you can't do a traditional Nissen fundoplication. The contraindications are the typical ones you might expect, patients who are children or pregnant, who do not have a diagnosis of GERD, who have large hiatus hernias, and have other motility problems such as achalasia or incomplete relaxation, or in general are poor surgical candidates. It's a very safe procedure. As you can see here, the adverse events are very, very low. And I'm often asked, how do you propose this to the patient? You tell them, how do you explain to them that you're going to zap them with electricity? And basically, I explain to them that this modality, this treatment occupies a middle ground between medicine and revisional surgery, and they seem to understand that. Many patients, the majority of them are off acid medications. There's a normalized acid exposure in 30% of patients and very few side effects and with high satisfaction scores. I myself conducted a study back when I was in Pittsburgh, it got published when I was in Indiana, on the application of Stretta in patients who'd had gastric bypass surgery. And I was actually very pleased to see that we were able to report both objective and subjective improvements. And you can see from this study that we had improvements in both the Demister score and the acid exposure, the esophageal acid fraction time. And this is another way of showing that data. The Duke people also, they studied their patients. So my study was in gastric bypass. This study is in sleeve patients. They had 5 patients. 4 had full remission of symptoms, and 1 had improvement. And we are actually in the process now of conducting a multi-institutional study. We're reviewing the protocol as we speak. So in summary, there is a small but significant proportion of patients who have very troublesome, very refractory GERD after bariatric surgery. And these patients have very few options. You cannot offer them a Nissen fundoplication. And so the Stretta application offers a safe and effective solution with proven objective and subjective benefits. Thank you very much.